Hello, my name is Carlisle Richards Jr., and my paper is entitled Wellness and Retention Program, a prevention-focused strategy for workforce stability, psychological safety, and high-quality patient care. My program focuses on a question that has become increasingly important in behavioral health. How do we care for people who spend every day caring for others? At Nassau University Medical Center, our behavioral health staff work with patients and families during some of the most difficult times of their lives. That work is meaningful, but it can also take a significant emotional toll. I developed the Behavioral Health Workforce Wellness and Retention Program as a practical response to that reality. The program brings together burnout screening, resilience education, peer support, leadership development, employee recognition, and ongoing evaluation. In this presentation, I will explain why the program is needed, how it would operate, how success would be measured, and how it could be sustained over time. Behavioral health professionals routinely work with trauma, suicidal behavior, severe mental illness, substance abuse, aggression, and complex family or social circumstances. In my experience, the clinical work itself is only part of the pressure. Vacancies, documentation requirements, limited resources, and growing service demands can make an already difficult job even harder. When that pressure continues without enough support, employees may become emotionally exhausted, disengaged, or more likely to leave. The effects are then felt across the department. Remaining staff carry additional responsibilities. Continuity of care becomes harder to maintain, and the organization assumes the cost of recruitment, onboarding, and overtime. This is why I view burnout as more than a personal wellness issue. It is also a workforce quality and patient care concern. The target population includes the full multidisciplinary workforce within Nassau University Medical Center's Department of Psychiatry and Behavioral Health. That means psychiatrists, psychologists, nurse practitioners, nurses, social workers, counselors, rehabilitation professionals, case managers, and administrators. I chose a broad target population because behavioral health care depends on teamwork. Stress experienced in one discipline rarely stays confined to that group. It affects communication, coverage, morale, and the overall functioning of the department. Participation would be voluntary, and individual assessment information would remain confidential. The program would also need to accommodate different shifts and service areas. Employees must understand that the purpose of this support, not discipline. Without that trust, people may participate superficially or avoid the program altogether. Rationale. A central idea behind this proposal is that employees should not be asked to solve organizational burnout entirely through personal resilience. Individual support still matters. Staff can benefit from recognizing burnout early, strengthening coping skills, connecting with peers, and knowing when to seek additional help. However, The organization also has responsibilities. Supervisors need the skills to respond supportively. Employees need psychological safety, and leaders must be willing to use feedback to improve workplace practices. I designed the program around this shared responsibility model. The goal is not to choose between supporting the employee and improving the work environment. We need to do both. That balance makes the program more realistic and more respectful of what behavioral health professionals actually experience. The logic model shows how the program is expected to move from resources to results. The inputs include leadership support, qualified program staff, assessment tools, and an annual budget of approximately $491,000. Those resources support the actual work of the program: screening, education, peer support, leadership training, and wellness activities. The immediate outputs are concrete and countable, such as enrollment, sessions delivered, completion rates, and utilization. From there, I would expect to see lower burnout, stronger engagement, less absenteeism, and improved retention. The longer term goal is a more stable workforce and a healthier organizational culture. An important assumption runs through the entire model. Employees must have confidential and practical access to the program, and leadership support must remain consistent. Goals and objectives. The program's broad purpose is translated into specific targets so that success can be evaluated honestly. By the end of the first year, the goal is for at least 75% of participating employees to show a minimum 20% reduction in burnout scores on the MAS/burnout inventory. Retention is expected to improve by 15% compared with the previous fiscal year, while stress-related absenteeism is expected to decline by 10% from baseline. The intermediate objectives help us see whether the program is moving in the right direction before the final results are available. These include participation in resilience and leadership training, improved perceptions of organizational support, and stronger employee engagement scores. I selected measurable objectives because a wellness program should be judged by more than attendance or positive comments. Program design, program components. The program has 6 connected components. First, screening establishes a baseline for burnout, engagement, satisfaction, and absenteeism. Second, resilience education gives employees practical information about compassion fatigue, emotional regulation, mindfulness, sleep, and work-life balance. Third, peer support creates a structured space for staff to talk with colleagues who understand the work. Fourth, leadership development helps supervisors strengthen communication, coaching, psychological safety, and trauma-informed supervision. Fifth, wellness and recognition activities reinforce healthy practices and show employees that their contributions are noticed. Finally, continuous quality improvement keeps the program responsive by reviewing participation, outcomes, cost, and feedback. I do not expect any one component to solve burnout. The strength of the program comes from using these strategies together. The flow begins by informing employees about the program and inviting them to enroll voluntarily. Participants then complete baseline assessments, which give the program a clear starting point. After that, employees can take part in wellness education and peer support, while supervisors participate in leadership development. Department-wide wellness and recognition activities reinforce the message that employee well-being is an organizational priority. The program team reviews participation and implementation every quarter, followed by a more formal outcome evaluation. What matters most to me is the feedback loop at the end. Evaluation should not simply produce a report that sits on a shelf. Findings should be used to improve scheduling, content, access, leadership practices, and the allocation of resources. In that sense, the program is designed to learn as it operates. Formative evaluation takes place while the program is operating. It helps answer a very practical question. Are we actually delivering what we said we would deliver? I would track enrollment, assessments, workshops, peer support sessions, leadership training, attendance, and completion. I would also look at participation by discipline and shift because a program can appear successful overall while still failing to reach important employee groups. Cost efficiency is another part of formative evaluation. Leadership needs to know the cost per participant, the cost of major activities, and whether staffing and technology resources are being used responsibly. Monthly and quarterly reviews would allow the team to identify barriers early. If scheduling, confidentiality concerns, or communication problems are limiting participation, we should make adjustments before those problems affect the final results. Summative evaluation looks at what changed after employees had enough exposure to the program. The primary outcome includes burnout, engagement, job satisfaction, organizational commitment, retention, turnover, absenteeism, and sick leave use. I would also examine cost effectiveness by comparing program expenses with possible savings related to recruitment, onboarding, overtime, and turnover. The purpose is not to force every benefit into a financial calculation because employee well-being has value beyond immediate savings. However, leaders still need credible information when deciding whether to continue funding the program. Components that demonstrate meaningful results can be maintained or expanded. Activities with weak outcomes or limited participation should be revised. Evaluation is most useful when it supports honest decisions rather than simply confirming what program leaders hope to find. Performance measurement gives leaders a fuller picture of how the program is working. Coverage asks whether we are reaching the intended workforce. Equity asks whether staff across disciplines, shifts, and employment categories have fair access. Process looks at whether the program is being delivered as designed. while effort measures how much service is actually provided. Cost efficiency considers the resources used to produce those services. Results examine changes in burnout, engagement, retention, and attendance. Cost effectiveness compares the investment with the organization, and impact considers whether the changes will last. I find this framework useful because it separates activity from effectiveness. A program can hold many workshops and still fail to improve the employee experience. These 8 categories help us see the difference. For the impact evaluation, I selected a quasi-experimental, non-equivalent comparison group design. Employees in the intervention group would complete baseline measures, participate in the program, and then complete follow-up measures. A comparison group would complete similar assessments over the same period without receiving the full intervention. The analysis would compare the amount of change in each group rather than comparing follow-up scores alone. This matters because the two groups may not begin at the same level. Random assignment would be difficult in an active hospital environment, and participation in wellness services should remain voluntary. This design does not eliminate every alternative explanation, but it provides stronger evidence than a simple before and after assessment. Interviews and focus groups would also help explain the quantitative results. The proposed first-year budget is $491,370. Direct program costs account for $446,700, with indirect costs estimated at 10%. Personnel is the largest expense because the program needs consistent leadership, daily coordination, clinical expertise, peer support facilitation, data analysis, and administrative help. The remaining funds support training, assessment tools, educational materials, wellness activities, employee recognition, technology, data collection, and outreach. I understand that this is a significant investment, especially in a financially constrained public healthcare environment. That is precisely why the evaluation must examine both outcomes and costs. The question is not only what the program costs, but also what continued turnover, vacancies, overtime, and burnout are already costing the organization. A sustainable program cannot depend on one temporary grant. Nassau University Medical Center should provide the operational foundation because institutional investment signals that workforce wellness is a genuine priority. New York State Office of Mental Health Opportunities may support workforce development, training, peer services, or organizational improvement. When an active procurement aligns with the program, HRSA administrators behavioral health workforce programs, while SAMHSA grants may support service capacity, trauma-informed care, peer support, or related workforce activities. Foundations, universities, professional organizations, and community partners may contribute funding, training, research, or technical expertise. My approach is to use external funding to launch, evaluate, or expand the program while gradually incorporating effective components into routine departmental operations. That is more sustainable than rebuilding the program whenever a grant cycle ends. I want to end with the central message of this proposal. Workforce wellness is a patient care strategy and an organizational responsibility. Behavioral health professionals cannot consistently provide compassionate, high quality care if they feel chronically depleted, unsupported, or replaceable. At the same time, a credible wellness program must do more than offer occasional activities. It must address leadership, psychological safety, access to support, employee recognition, and the workplace conditions that contribute to burnout. Developing this proposal reinforced my belief that leadership is not limited to managing budgets, staffing, and compliance. It also means creating an environment where employees feel valued and able to do meaningful work without sacrificing their own well being. With sustained commitment and honest evaluation, this program could strengthen employees, patients, and the organization as a whole. Thank you.